with previous surgery and a stoma has been created in this case. We like to know the history from one of the students, and then we will discuss the case as per the clinical findings.
I am presenting a case of Mr. Pawan, a 22 years old male resident of Ita, and he is an electrician by occupation. He came to emergency, JNC emergency on 2nd August 2025, and on examination
with chief complaints.
Okay, with the chief complaints of pain in abdomen, distension, and
vomiting,
unable to pass feces from 1 month, for which he was examined and he was investigated, and was found to be a case of perforation peritonitis, for which emergency laparotomy was done and a stoma was created. And now he has come for
आपका ऑपरेशन कब हुआ था, कितने दिन हो गए?
2 तारीख को
2 तारीख को, और आज 22 तारीख है ना, 20 दिन हो गए. Okay, so as you have heard the history that this patient came to our emergency with severe abdominal pain, vomiting, and absolute constipation, and he was clinically examined, and a diagnosis of peritonitis was made, and he was further investigated, and there was gas under diaphragm, and with that finding and suspicion of perforation peritonitis, exploratory laparotomy was done. What were the findings of exploratory laparotomy?
So ileal perforation from the ICJ, 1 into 1 centimeter ileal perforation,
Proximal to
ICJ.
So there was a ileal perforation, 2 feet proximal to ICJ,
1 into 1 centimeter, single perforation.
Single perforation was there, which was closed. And then why this stoma was made?
Stoma is made because the bowel was contaminated and patient nutritional status is not good.
So and how many hours had passed when the pain started?
About 3 days.
3 days. So this thing is very important, that the prognosis of the patient as well as the decision regarding creation of stoma has to be made after the time elapsed from the initial pain. So in this case it was 3 days, which is a very long time. So we assume that the perforation had occurred 3 days earlier when he presented to the hospital, and he was being treated conservatively in different hospitals in private setup, but he was not getting relief, and that is why he came to this hospital where the diagnosis of peritonitis was made. And during surgery it was found that there is an ileal perforation which was quite a significant size, and there was peritoneal contamination, and the bowel was not healthy. So these are the preconditions in which we do not do a primary closure. If it's a small perforation and less than 5.5 centimeters and there is no bowel contamination, we can only do a primary closure and there is no need for a stoma. But in a situation like this where the disease is 3 days old, there is likely to be contamination of the peritoneal cavity, plus there is also the size of the perforation is also important, and if there are multiple perforations also is one of the indications for creating a stoma. So not all patients with perforation peritonitis require a stoma, but there are specific indications, and in this particular case some of the indications were there, that it was 3 days old and the size of the perforation was size more than 1.5 centimeters, plus there was fecal contamination of the peritoneal cavity. So these are the common indications for doing a ileostomy and not doing a primary closure. So now the primary closure has been done and the stoma started functioning and he was discharged home. So now he has come for follow-up, and as you can see there is the main on abdominal examination. If you inspect, then you find that he is having normal respiratory movements, and there is a midline scar which is having many areas of wound dehiscence, and the stitches are still in place, and then there are two small openings which are healed on the left side. They are the sides of drains which was put, and there is mild pus present in the ulcerated areas, and rest lower wound is healed. The upper wound is having wound dehiscence. So overall, there is mild sepsis in the main wound. The drain sites have healed, and I think it is the appropriate time to remove the stitches. So once the stitches are removed, the wound will look much cleaner than what it is now, and only mild dressing of the main wound needs to be done. There is no need to suture it as of now, as there is some pus, and I think within 3 to 4 days with dressing the wound will heal and it will be ready for secondary closure if at all it is required. So the main wound is dealt with just by secondary closure or by dressing. Now come to the site of Isquata. Remove this. Clean करके हटा फेंक दो नीचे. Now as you can see the stoma site, there are two openings. One is the distal one and one is the proximal one. From the proximal one some fecal matter is coming out. So that is the proximal opening. So the proximal opening is functioning and formed fecal matter is coming out with some liquid which is of normal content. From the lower opening there is no discharge because it is a distal part and it's having only mucus which will be coming at if it is all coming regularly. So whenever we make a stoma, there are two openings in this type of ileostomy. One is the proximal and one is the distal. The proximal one is having a continuity with the food particles which the patient is taking, and the second one is not having any communication. It is the distal end and hence it will not be functioning. So now we have to decide, first of all, it is a healthy stoma because the color is normal. He is not having any prolapse. There is no reduction of the stoma, and it is functioning properly. There is no special infection or discharge in the surrounding skin is also normal. It is firmly in place, and he is able to clean it 3 to 4 times per day. So, and you can see the discharge coming out, which is there, and it is almost near normal discharge. So, this is a nicely functioning stoma, and there is no need to change the present treatment. Now the question is that now we have created a stoma, so how long this stoma should stay? Because this is not the right place for the fecal matter to come indefinitely in a young man. So it is not an end stoma, it is a stoma which has been temporary stoma. So there are two types of stomas, one is permanent and one is a temporary. So in this case, it is a temporary stoma to take over the crisis of the surgery and the infection which is there in the peritoneal cavity. So usually we give a time of 6 to 8 weeks. So after 6 to 8 weeks, we will do sinogram and distal hologram. In this case, it will be lupogram. So that lupogram will dye will be injected in this distal segment, not in the proximal segment, and that will take care of the distal picture, and we will see till it comes out through the rectum. So if the distal segment is normal, there is no obstruction, there is no leakage of the dye, and everything is fine. Presently the patient is looking healthy and he has no complications. So we can close this stoma after 8 weeks. And once the distal segment is patent, then a closure of the stoma will be planned. Now in this case the closure will be very simple because it is already the bowel is already exteriorized. So what we have to do is we have to free it from the wall and then make it straight, and then the anterior wall has to be sutured. And once that is done, it is pushed inside the abdominal cavity and the muscles are repaired and a drain is put in place. So that normally in 80 to 90% of cases heals by itself. So there is no chance of burst or regress until it is fixed by the other suturing, etc. Otherwise, it's a normal procedure. So what we will do, we after already 4 weeks have passed, another 2 weeks we will wait, and then we will do a distal cologram, distal lupogram, and once the distal lupogram is intact, we can start the process of preparation. So we have to prepare the bowel, the proximal bowel as the distal bowel. Distal bowel, only enemas will be required, and proximal bowel we have to be kept nil per orally for 2 to 3 days, and only IV fluid or liquid diet will be given, and then the primary closure of the stoma can be done. So I think in this case, we are going to have a good heal, and we can close the stoma after 2 weeks. Colostomy will have more wider openings, plus there will be tinea on the sides, and will be formed fecal matter, because by the time the stool reaches the ileocecal junction, it gets solidified, and the proximal, as it starts moving, it is more absorbed. The fluid which is in the fecal content is absorbed. So the fecal matter is hard and solid, and you can identify with the stoma and the wider opening which will be present. And the indications will be different why it has been done.